Our first speaker to give the inaugural address today is Lt General Bipin Puri. Lt General Bipin Puri is a well-known personality from Lucknow, a student of La Martiniere, Lucknow, alumnus of the Armed Forces Medical College, Pune. The general officer was commissioned into the AMC on March 30th, 1979. He did his post-graduation in general surgery in 1985, his specialization in pediatric surgery from PGI Chandigarh in 93, and fellowship in pediatric urology at the Birmingham Children's Hospital, UK in 1997. The general officer is commanded Command Hospital, Northern Command, Udhampur, and 155 Base Hospital, Tezpur. He's also served as MG Med Headquarter, Northern Command, Director General Medical Services, Navy, and DGMS Army before taking over as Director General Armed Forces Medical Services in October 2017. He was appointed as the President's Honorary Surgeon on June 1st, 2016. He was conferred the VSM in 2017 and the PVSM in 2019. He superannuated in 2019. The Governor and Chancellor of State Universities, the Governor of UP, Mrs. Anandabhen Patel, appointed him as the Vice-Chancellor of KGMU, an appointment he assumed on August 10, 2020. He is the first Army General to be made the Vice-Chancellor of any medical university in the country. May I request General Puri, sir, to please deliver the inaugural address.
Good morning to all in one. I bring to you all greetings from the King George Medical University. At the outset, let me begin by saying my compliments to the organizers of the Strife India webinar platform, a platform which I'm told has been raised by the veterans, of the veterans, and for the veterans. So thank you, General Kakkar sir, for your kind introduction. A special thank you to Colonel R.P. Singh, who has been the prime driver, so to say, for pushing us into this presentation. Well, friends, gentlemen, let me begin by saying that the past year or so, there has been a sort of a knowledge overload on COVID, from whether it's from the print, from the electronic media, or the social media, the WhatsApp medicine, as they keep calling it. So I'm aware that today, as I talk, I'm not talking, though I know I'm not talking to doctors primarily, but I'm talking to people who have now, over the time, become specialists and super specialists, and they know it all as far as COVID medicine is concerned. So that makes it a very knowledgeable audience, and that makes my task simpler. So I plan to take you through this presentation, talk about the virus origin and its carnage so far, just a profile to get it going. Talk about the COVID-19 evolving disease, because as doctors, as healthcare professionals, this is what has confounded us as far as the COVID-19 infection is concerned. How the second wave was different. Will India face a third wave or perhaps subsequent waves thereafter? How is vaccination going to make a difference? The mutants, are they a concern? And how are they changing the profile of the COVID management? The KGMU experience, the black fungus. As you are all aware, we saw the largest center of black fungus in the state. And of course, I will conclude with some key messages. Well, friends, ladies and gentlemen, I begin by talking about the SARS-CoV-2 virus, which is a novel beta COVID virus, a mix between the SARS and the MERS virus, which has been talked about by General Kakkar. But having said this, December 2019, Um, uh, Donald Trump liked to call it the Chinese virus, and I will go by that terminology. And it was declared as a public health emergency of international concern by the WHO on the 30th of January 2020. Now, why I bring out this landmark milestone is because it changed the dynamics in the world. It was declared a pandemic on the 11th of March. And as General Kakkar very rightly said, as we know that there is a primary host, which is the bat, there is a secondary host, which could be one of these and potential animals or mammals. Man is only an accidental host because the virus cannot propagate thereafter. So therefore, it has to be one of these, which is the secondary host. We still don't know what. Well, what we do know is that the virus spreads by infected droplet, and now we are talking about it being airborne as per the last Lancet report, which talked about it being airborne. And of course, a direct contact, nosocomial, that is hospital-acquired infections, are the other modalities of spread of the disease. A word about the global situation. As you are aware, more than 174 million cases, deaths, more than 2.7 million in the world. But talking of India, the Indian situation, 2.89 crores in India is what is documented, and 3,51,000 deaths documented in India. So that's how colossal the mayhem and devastation and the carnage that has happened. So I'll just run you through. I'm not going to get into the medicine of all this, but I will talk about how our understanding of doctors has changed as far as the virus has evolved over the past year or so. We know that the virus enters through the airway, and when it comes in, there is this so-called ACE2 receptor in the lungs, what we call the alveoli, and from where it finds entry into the alveolar cells. It is an RNA virus. It comes into the nucleus, mixes up with the DNA, and then it becomes an antigen. It starts a cascade of inflammatory changes and inflammation, which happens locally, which results in cell death, but can also go all over the body. And we'll be talking about this now here. This is what we talked about. Transmission, as we said, could be droplet, airborne, or fomite. Now, this is questionable. Fomites is like objects. Can it be transmitted by objects? So that is, of course, questionable. But there continues to be research even on this aspect as well. Now, the symptoms of the COVID infection, we are all aware, have been so diverse. The respiratory is what we hear of, the drop in saturations and breathing difficulty, etc., etc. But clotting disorders, blood clotting all over the body, is another very, very important cause and has been seen as varied manifestations, especially in the second wave. Gastrointestinal symptoms like diarrhea, pain abdomen, and also now we are talking about gangrene of the intestine is now being reported as a result of clotting in the blood vessels of the intestine. Liver dysfunctions, heart problems of the heart, as you're aware, can either be the electrical system, it could be the muscle, or it can even be a coronary block. So such are the diverse spectrum of COVID manifestations as far as the heart is concerned. And as far as the brain is concerned, that is called the central nervous system. Let me just give you an example of my own father-in-law, whom I lost just a few weeks ago of COVID. He had a drop in his saturation. He was COVID positive, but he had no respiratory symptoms. He had no breathing difficulty, and yet he slipped into coma. And that coma was actually a COVID involvement of the brain, what we call as a COVID encephalopathy. So another manifestation has come up in recent times where the COVID involves the brain. And that is something which requires. So the point which I'm trying to make is this: the spectrum of the problem could be so diverse across every possible system of the body. Now, let me talk just a word about treatment modalities. Now, here again, what has happened is, from the time to time, the WHO keeps modifying, keeps analyzing data about the various treatment modalities which are being followed across the world. So one of the largest trials, which was called the Solidarity Trial, looked at various drugs which have been used in the treatment of COVID care. So talking about antiviral drugs, we know very commonly in our practice, we were using these ivermectin and azithromycin or doxy combinations, going on to favipiravir and remdesivir. Now, these are some of the antivirals that we have been using. The problem is that WHO finds that many of these drugs are not good enough and not really required. And therefore, questions are being raised about the effectivity and whether we actually require to give these drugs. A word about anti-inflammatory drugs. We know that one thing which has found great favor as far as the treatment is concerned is steroids. Dexamethasone 6 milligrams per kilo for adult dosage has been found to be a standard of care and has been found to be a game changer. But let me make a small point here in this context. In the second wave, we have found a large number of patients coming to light as diabetes mellitus. They were never diabetes, they never had diabetes, but because they were exhibited steroids, a hidden diabetes came to light. And that's something which we found in the second wave. And this is across the board, everywhere. This is a finding that has come up. So pre-diabetes is an entity that we require to be careful about. A word about this so-called monoclonal antibody, the cocktail, monoclonal antibody cocktail, which is the Donald Trump cocktail, as they like to call it. And in fact, on a lighter vein, let me share this. My brother one day asked me, what sort of cocktail is it? Can we have a drink on this sort of a cocktail? But that's how it was. But this gentleman is a very specific antibody cocktail which takes care of the COVID virus. Now, immunomodulators, as you're aware, are things like the tocilizumab, and these are drugs which have found favor initially, but now are under scrutiny because in liver and renal dysfunctions, it cannot be used, can be used only in mild to moderate disease, but when the disease is severe, they have fallen out of favor. So much so for the changing profiles of the pathophysiology, transmission, presentation, and treatment modalities. Now let's talk a word about COVID-19 second wave. How was it different? Most important to note that there were hugely large numbers in a very short span of time. So as you know, the first wave was spread over about 8 months. The second wave was over a higher peak, much higher volume over just 6 weeks. And that is, so it overwhelmed the healthcare system of the country, and therefore the mayhem and all the destruction. Well, what has come to light is different spectrum of presentations, which I talked about. But what is another very important presentation which has come to light is what is called as MIS-A and MIS-C. Now, this is something which I will be talking about, which is of relevance to our veterans and something which is of extreme importance to understand, and because it diagnosis of MIS-A, this is the multi-systemic inflammatory syndrome of adults and multi-systemic inflammatory syndrome of children. Now, this is something which has come to light, and I think this is of extreme importance. Now, there are a couple of questions. Are more young people getting infected in the second wave? The answer is no. The older population continues to be the vulnerable population, and I'm glad that we took decisions of taking care of the over 60s. The government took a decision of taking care of the over 60s, and as far as the younger generation, you can see in the graph, this bar chart, you can see this is the first wave and this is the second wave. And as you can see, the numbers, though the numbers were higher because a higher volume of patients got infected in the second wave, but the difference between the age group, if you look at the age group, whether it's 0 to 19, 20 to 24, or more than 30, the difference in the first and second wave was hardly there. So therefore, not much of difference as far as the numbers of the younger population. More than 70% of patients are under 40 in both the waves. Now that's important to understand because, as you know, the older ones were immunized earlier, and therefore they were the ones which were protected, and that was rightfully so. This is what has happened. Now, the other very important difference between the first and second wave was, whereas in the first wave, the presenting symptom was throat pain and a sore throat and dry cough, whereas in the second wave, the predominant problem was breathlessness, a drop in oxygen saturations. Now that created a panic reaction. And that was perhaps rightfully so, because there was a drop of oxygen and there was a dire need for effective Medicare. Now, what it actually happened was, as a result of in the second wave, it required increased oxygen demands. Now, the ICMR has released this data, as you can see, that there was a 54.5% of the patients required oxygen in the second wave, and it was only about 41.5% who required oxygen in the first wave. So there was a substantial increase of requirement of oxygen, and that was one of the limiting factors, as you can see, because oxygen was not available in as much time, and there were logistic and administrative issues, which again further increased the problems. There was a second problem: mucormycosis, the black fungus. And that is, and I have one slide even on mucormycosis. I'll be talking about this. But I think the most important thing for our veteran colleagues who are in higher administrative posts, who can understand what it actually means in management challenges, I think it's important to have the granular data for data sharing for treatment decisions, because there is so much happening in different centers, and unless we are able to collate, synergize, and coordinate this data, you cannot supply the quantum of supplies that you require, whether you're talking of the personal protection equipment, you're talking of medical, surgical supplies, the ICU bed delineation and alignment, how should you, where should you, so how should that coordination, I think at a macro level, I think that perhaps is going to be very important if at all we have a third wave, and that is something for the country to learn. So I talked about the increased oxygen requirement in the second wave, and this, of course, was the black fungus, which I shall be talking about in a minute. Will India witness a third wave? In the words of Professor Raghavan, who is the scientific advisor to the Prime Minister, the third wave is inevitable. Now, the fact of the matter is, how is it going to behave? The third wave is going to come. We are absolutely certain about it. How strong is going to be the third wave, we don't know, because there would be so many intangibles, so many imponderables, which would dictate whether the virus, in an attempt to survive, when it mutates, does it become stronger or does it become weaker? Now, that is something which requires to be assessed from time to time. We require to do what we call as the NGS, the New generation sequencing from time to time to see how the virus is behaving. And towards that extent, I think the government has left no stone unturned to try and look at various issues, problems, challenges which face the country today as we look and stare into the third wave, which we don't know when is it going to come and how is it going to come. And is it going to be only children, or is it going to be children and adults? And so what is going to be the combo? What is going to be the process, and how do we take it forward? Now, friends, gentlemen, let me say this. The key to protection from the third wave is going to be vaccine. It depends on the government's vaccine policy. Can we do it is the big question. Can we procure? Can we implement? Can we have our cold chains? Can we look into the problems of administration of the vaccine? It's a humongous task. And to get it going, I think that's important. I'm going to make a couple of, give you some inside information in the next 1 or 2 slides, something what has happened and what is the status of serosurveillance studies. Now, the special task force was activated by the government to protect children from the third wave. Their studies have come in and they have made some recommendations, and they have talked about how we need to protect our children. Now, the important difference I want to make a point here, there's a lot of hype that the children are going to be affected by the third wave. But the children are protected by 2 things. One, they have an innate immunity by virtue of taking their vaccines during the first few years of life. They have an innate immunity which they carry, and there's a cross immunity against various infections. Having that, of course, is one. The second thing is their body systems are more resilient, number 2, and that there's a third reason. They don't have many comorbidities like diabetes, hypertension, and ischemic heart disease. If that be so, the children, the prognosis is much better. So therefore, even if the children get it, they bounce back to normalcy. And therefore, the world experience has been that children, even if they get COVID infection, is usually very mild, and they bounce back without much of a problem. Now, will vaccination make a difference? Now, I have just clear statistics, and this is from across the world, and it says that if 40% of the population is vaccinated, it reduces the risk of infection by 85%. Now, and if it also reduces the risk of death by 87%. Now, huge statistics, very incriminating statistics, which tells us why vaccination will make a difference. The other thing is that we have found the current vaccines that we are at the moment available in India. I'm talking of all 3, including the Sputnik V vaccine, besides Covishield and the Covaxin. All 3 have been found to be protective against the variants, the current variants. I'm talking of the current variants. I'll talk about the variants in a minute. But I think the most important thing is we as the seniors, we as the administrators, we as healthcare professionals, we need to indoctrinate a thought process into the society at large that there should not be any vaccine hesitancy. And yes, we've seen this in our country. We have seen this problem so much so in Lucknow itself. The other day, it was in the news and crossed many channels and TV as well as in the print media. In Barabanki, one team went to do the vaccination, and the villagers, they dived into the water. They just didn't want to be seen with the vaccinating team. They just wanted to avoid the vaccination. So vaccine hesitancy is indeed true, and it requires to be addressed. It requires to, at different levels of people, of society, need to reach out to the most peripheral people, the rural poor, the illiterate people, to tell them that there is a huge advantage of going in for vaccines. And therefore, as I say, from refusal to take vaccines, the other end is a demand for vaccines is what we want. A situation which should come is that we demand vaccine. I think that's the India that we are talking about. So I'm going to talk a word about what is the mutants is really, gentlemen, a cause of a concern. The WHO has classified these mutants as in 3 major groups: variants of interest, which was, the initial virus which came in. They call it the UK virus, the US virus, the Brazilian virus. Those are the variants of interest because that's how the COVID infection started. But now is the concept of variants of concern. Now, these are variants of concern because these mutant variants have created mayhem. They are more transmissible, they cause more damage, and they are really a subject of huge research as to how should we tackle these viruses. Variants of high consequences, thankfully we don't have any at the moment, and I hope we don't reach to this level. So we are stuck with the variants of concern, and I want you to make a note of this, that these Indian viruses, the Indian variants, especially this one, B1.6172, the Delta virus, is the one which caused mayhem in the second wave. And this is now under huge scrutiny and research all over the world. Now, if you look at the various sequencing which has been done all over this country, all over the world actually, they have found 80 plus important mutants which are a cause variants of concern. But what the global literature is talking about is the one which is the mutant from India, which is of largest concern as far as the mutants is concerned. And that's the point which I'm trying to tell you. The second wave which we went through absolute disaster. And this variant created mayhem because it was hugely transmissible, which means that spreading infection from one person to the other was very simple, and of course it caused huge destruction. A word about the KGMU experience. As some of you are aware, we started one of the largest COVID care facility in the state, 1,000-bedded COVID facility of more than 400 ICU beds. Since April last year, we had more than 7,000 admissions, more than 6,000, of course, were discharged. Total admissions in ICU were in the ICU, and I'm talking, these were very, very sick patients, were as many as 4,000. Total patients who were ventilated were as much as 1,800. And out of these 1,800, we managed to save about 25 to 30%. We lost the rest of the patients who came on ventilator. But this COVID care facility that we had, it had a dedicated labor room, it had an operation theater complex, it had dialysis facilities all under one roof. We ran the largest COVID testing capability in the state and have done more than 19.5 lakhs till date. And even today, we do about 9 to 10,000 tests every day. We started the KGMU Plasma Bank in the state and put up these plasma banks in various other hospitals and colleges in the state. Now, a word about these deadly Mucor, which we have seen. As you can see, one of the largest experiences of the black fungus in the state, perhaps in the country. 328 cases we have had of the black fungus infections. We have discharged about 45 of them. About 41 have expired, which is about 12.5% mortality. Let me tell you that world over, the mortality of mucormycosis is 50%. And we have been somewhat lucky. We have not had such a bad result. Our mortality has been about 12.5%. About 252 out of these 328 have undergone surgery and clearance of the black fungus. And we have started a couple of new things I'll be showing you in the next slide. I'm not going into the medicine of this case. And just to give you a profile, this was a patient, a diabetic who came to us, who was a proven COVID patient. It was known that he has COVID pneumonia. He was on steroids, inhalations, and he came to the hospital. We diagnosed him to be having mucormycosis by fungal examination. He was put on drugs. He was put on medicines, the so-called amphotericin. But what happened was the infection, the fungus entered his brain. And this is what it was. Have a look at this picture. The infection having come into the brain, the neurosurgeons got activated. They were waiting to go in and see if it's required to take out this infection. But then what happened was we started this patient on hyperbaric oxygen. Hyperbaric oxygen is oxygen under very high pressure, which we normally give in high altitude. So we started this patient on hyperbaric oxygen. We gave him 12 sittings. Over a period of time, we found that this patient was actually improving. And within about 15 days, you can see the entire infection cleared. So we have now made this as one of our treatment protocols of offering hyperbaric oxygen to some of these black fungus patients based on definite indications. So, so much so for black fungus. Now a word about post-COVID, something which is relevant for our veterans, as we have seen that the profile of the disease has continued to change and evolve over a period of time. A wide range of new problems have come up. Patients have been discharged from COVID disease. They come back to the hospital after about 4 weeks and with symptoms. And I'll talk about those symptoms. And there were also some admissions of patients who actually never got admitted. There was some history of having a short febrile illness, but not getting admitted, but coming back 4 weeks or 6 weeks later with symptoms. And these symptoms are now being called as long COVID or long haulers, and in which various organs are being damaged. And we are now seeing multi-organ inflammatory syndrome. And this is a problem of which is now also what we are seeing is the effects of COVID-19 treatment, the complications of the treatment, what we have given these patients, the sequelae of the treatment, like when you give steroids, a resultant diabetes which lingers on. So those effects are coming to light. And besides, of course, when you give them immunomodulators, when you interfere with their immunity, when you give them steroids, when you give them drugs like tocilizumab, which are immunomodulators, you are making them more susceptible to bacterial and fungal infections. And lastly, another problem which has come to light is blood clots all over the body. And that's something which I shall talk about. Now, as you can see, long COVID, as they call it, long COVID can last for weeks or months after being infected with the virus. It can appear weeks after the infection, can happen to anyone who has had COVID-19, even if the illness was mild or they had no symptoms. Now, that's what we are talking of as a terminology called as long COVID. A spectrum of problems. Now, how will you say whether you got long COVID? It could be just fatigue, difficulty in concentrating, what we call as brain fog, headaches, loss of smell and taste, which can actually linger on for a very, very long time. Dizziness on standing, palpitations, chest pain, difficulty in breathing. Now, here is a point I would want to educate my veteran colleagues. The 6-minute walk test is a wonderful way to see whether your lungs are affected. What it effectively means is that you wear the pulse oximeter on your right middle finger, and you walk for about 6 minutes. You just walk around and see if there is a 3% drop in the oxygen saturation. It is suggestive of a positive 6-minute walk test, which suggests that your lung functions are partially compromised and you require medical advice. The 6-minute walk test is something which I thought I must make a mention. So you can have cough, joint pains, depression, anxieties, fever, symptoms that get worse after physical or mental activities. I talked about the multi-organ inflammatory syndrome, which we are seeing, which is usually coming up after 3 to 4 weeks after the initial infection. And this is how it presents: fever coming after 4 weeks of a COVID infection, a low blood pressure, gut, abdominal pain, vomiting, diarrhea, rash, chest tightness. And this, friends, gentlemen, can be very, very serious, because this is an expression of the inflammatory response, a hyper-inflammatory response, and these patients can go into shock and die. And therefore, they require aggressive treatment by what we call as intravenous immunoglobulins. And that is something which is critically important. We have saved many lives of patients of the MIS at KGMU, and I think this is important to remember. So how do you protect yourself from the MIS? And that the best way, as you can see, is to protect yourself from the virus. So to conclude, friends, ladies and gentlemen, key messages. I think we are, the COVID has defined a new normal in recent times. And I think we have to come to terms to this, adapting to the new normal. And the new normal, of course, what I'm trying to say is basically the COVID appropriate behavior is what we are talking about. Keep your distance, wash your hands, and stuff that we all know about. But I think the more critical things are boosting up vaccination, hygiene, and sanitation. Let me throw up a point to you all. The world asked a question. We've all had COVID, all of us, all over the world, even third world countries. Why is it that India is having so much of black fungus? We also had diabetics. We also had indiscriminate use of steroids. We also had immunocompromised people. But why are you guys having so much of black fungus? That is a question which the world asked the Indians. We analyzed our own data, and we found that perhaps this is a very important issue in our intensive care units. And I'm not something which we in the healthcare professionals have discussed it threadbare, and this requires to be analyzed in detail. And I'll give you a cue here. Have we seen enough of black fungus in service hospitals? No, we haven't. But we have seen it outside service hospitals. There's a difference. In service hospitals, hygiene and sanitation is a different kettle of fish. I don't say this because of my very long association with the Armed Forces Medical Service, but I say it with certainty because I have data to suggest that black fungus was not a major issue in the Armed Forces hospitals. Long COVID, friends, is going to be a very, very important issue. And as I said, because steroids have been used, high doses of steroids for a long time, many pre-diabetics have come to light, and that's something which is really a cause of concern. You require to have your sugars right and keep them under control. I think that's the message that I have for you all, and that is something which is very, very important. And my last point is about over-the-counter sale of antibiotics. Whereas, as you're all aware, in Western countries, this is prohibited. The over-the-counter sale of antibiotics is not allowed. Whereas in India, you can pick up whatever antibiotic you want by going to the chemist and picking up an antibiotic. This has resulted in the emergence of antibiotic resistance and the so-called superbugs. And this may also be an added cause of the fungal infections that we keep talking about. I think there's a need for us in different fora to talk about this issue. Is there a need for a legislation at the highest level, at the government level, to ban over-the-counter sale of antibiotics? I think once again, I thank the Strive India platform for giving me an opportunity to share some of very, very important issues which have emerged in the recent second wave of the COVID crisis. And once again, thank you, ladies and gentlemen, for your attention.
Thank you, General Puri. The talk was simply put, outstanding and informative. I think we could have had no one better to put us in picture as far as COVID is concerned. On behalf of Strive, I convey our immense gratitude to you for your enlightening presentation.